Hey everyone, and welcome. If you're gearing up for your IBCLC exam or you're just looking for a really clear, straightforward guide, you have come to the right place. Today, we are breaking down everything you need to know about contraception for breastfeeding mothers, all based on solid evidence. Let's get right into it.
This right here is the million-dollar question, isn't it? It's this constant tightrope walk between honoring a client's need for good birth spacing and our absolute #1 job, protecting that milk supply. So we're going to give you a clear framework to help you answer this question with total confidence.
So here's how we're going to tackle this. We'll start with the big challenge itself, the physiology behind it all. Then we're going to walk through what I call a hierarchy of choice, starting with the absolute safest options for lactation and working our way up. We'll hit natural methods, progestin-only, the deal with estrogen, what to do in an emergency, and we'll wrap it all up with a solid counseling framework you can use tomorrow.
So when it comes right down to it, we're juggling two really big things. A mom needs a birth control method that works for her, one she feels good about. But, and this is a big but, it absolutely cannot sabotage her breastfeeding goals. Our job is to lay out the options so she can make a choice that she feels totally empowered by and informed about.
And this slide right here, this is the why. This is the core science of it all. As soon as that placenta is delivered, progesterone levels have to plummet. It's the green light for the body to start making mature milk. And that's exactly why we have to be so careful about introducing hormones, especially in those early weeks.
All right, let's start at the foundation of our hierarchy. We're talking about the options that have zero, and I mean zero, hormonal impact on lactation. Honestly, this is the safest and most logical place to begin any counseling conversation.
First up is the Lactational Amenorrhea Method, or LAM. It's such a simple, elegant, and really powerful tool. This flowchart you're seeing is from the Academy of Breastfeeding Medicine, and it really just boils the whole thing down to 3 simple questions.
Here's a great little trick for the exam. The acronym LAM itself helps you remember the 3 criteria: lactation, amenorrhea, and months. Is she fully breastfeeding? Is she amenorrheic, meaning no period yet? And is her little one under 6 months old?
And get this, if the answer is a solid yes to all 3 of those questions, the data shows LAM is up to 98% effective. That is huge. It's an incredible, totally natural option that really supports and empowers mothers who are breastfeeding exclusively.
Now, LAM is fantastic, but it's not the only non-hormonal player in the game. You've got your barrier methods, things like condoms and diaphragms, and of course, the copper IUD. None of these have any known negative effects on milk supply. And that copper IUD is really worth highlighting because it gives amazing, long-term, hormone-free protection.
Okay, so what happens when a client wants or needs to go the hormonal route? Well, all the evidence points us down one particular path, and that's progestin-only contraceptives. This is the next step up in our hierarchy.
I love this table because it just lays it all out so simply. You've got progestin-only methods on one side, which, as you can see, are generally A-OK with breastfeeding. Then, on the other side, you've got the combined methods that have estrogen, and that's where we have to proceed with caution because of that risk to milk supply.
So when we say progestin-only, what are we actually talking about? Well, you've got the daily mini pill, the long-acting implant and injection, and then the hormonal IUDs, or IUS, like Mirena and Skyla. These are the main ones your clients will be asking about.
Let's geek out for a second and get really specific. What does the actual hormone transfer look like? Well, this number, 19.86 nanograms per kilogram per day, is the incredibly tiny amount of hormone from a Nexplant-on implant that actually makes it to the baby through breast milk. And the research is clear. This amount is so low, it's not linked to any changes in the baby's growth.
But, and this is so important for real-world practice, we have to balance the big studies with what we see in the clinic. Dr. Thomas Hale, who is a giant in this field, points out that even though the data says things are generally fine, his center gets a lot of anecdotal reports about milk supply dropping after a Mirena is placed. It's a powerful reminder to tell our clients to just keep an eye on things.
Okay, now we're climbing to the top of our hierarchy, methods that contain estrogen. And the key word here, the one I want you to remember, is caution. These are just not the first thing you'd recommend to a breastfeeding mom.
And this side-by-side really tells the whole story, doesn't it? Progestin is usually fine, but estrogen can actually work against lactation. I mean, historically, high doses of estrogen were literally used to dry up milk supply. So if a client does choose a combined method, the advice is always the same. Wait as long as you possibly can, use the lowest dose available, and only start once that milk supply is rock solid.
Okay, let's talk about those oops moments.
because, life happens and sometimes emergency contraception is on the table. It is absolutely vital that we know the safest choices for a mom who's breastfeeding.
Your go-to hormonal option here is going to be the progestin-only Levonorgestrel, or LNG. The research shows that next to nothing passes into the milk, and there's absolutely no reason to interrupt breastfeeding. The copper IUD is another fantastic non-hormonal choice, and it gives her ongoing protection. Ulipristal is another option, and while we don't have a ton of data, we do know the dose to the infant is pretty low.
Phew! We've covered a ton of information. So how do we wrap all this up into a framework that you can actually use when you're sitting across from a client? How do we empower them?
It really boils down to 4 key principles. 1. Always start with that hierarchy of choice, non-hormonal first. 2. For any client choosing a hormonal method, counsel them to just keep an eye on their supply. 3. Remember, this is about shared decision-making. We lay out the risks and benefits, she makes the final call. And 4. Document. This simple framework keeps your counseling safe, effective, and truly client-centered.
And that really brings us to the big picture, the final thing to chew on. As practitioners, we are on the front lines. We hear the individual stories that sometimes don't line up perfectly with the big, large-scale studies. And this question, how do we bridge that gap between the research and one person's lived experience? Well, that's both the art and the science of what we do every day. Thanks so much for joining me.